the hormonal changes, how will they affect the risk for females to develop autoimmune diseases?
Menopause and perimenopause are definitely the time where we do see an uptick in things like rheumatoid arthritis.
They are in pain, they sleep very poorly, and that affects their life.
That a lot of women are like, oh, it's me, I'm broken, I have low libido, I'm the problem. Men have 10 times as much testosterone as women, although women do have testosterone. And so it's more of a desire discrepancy.
There is a lot of discussion in the medical world about the role of estrogen. Is it really protective?
Estrogen protects you from bone loss, lowers your cardiovascular risk. Estrogen is good for your brain. Birth control pills put you at a much higher risk for blood clot than hormone replacement therapy.
Welcome back to another episode of Thriving with Arthritis. I'm your host, Dr. Diana Girnita, and today we're going to talk about a sensitive topic that affects many women with autoimmune diseases. We're going to talk about how autoimmune diseases will affect your sex life and what can you do to improve that. And I have the expert here, an expert in sexual health, also in menopause. I have Dr. Becky Kaufman-Lean. Welcome, Dr. Kaufman.
Thank you. Thanks for having me.
It's a pleasure. I know Dr. Becky Kaufman-Lean probably for about 4 years. She is the CEO and the founder of Evora Woman Health, a practice that I think revolutionizes the care of women with autoimmune diseases, but also other pathology. I know that you are double certified in OBGYN and also obesity medicine, and you're
Yep.
also a sexual counselor and board certified for menopause. But let me ask you a question, Dr. Lean. How it comes that a Southern California Valley girl
Yes.
got all the way to live in San Luis?
Yeah, so I didn't come here directly. I actually went via the East Coast. I went to school at Columbia in New York, and then I ended up at Georgetown for medical school, and I met my husband, and he is from Kansas City. So when I was looking for residency programs, we looked all over Missouri, but we also looked all over California. But we ultimately chose Washington University in St. Louis.
Excellent. I know that the Southern Californians are missing you. You know that I live now in South California.
Oh, I'm not sure I knew that.
Yes, I am in Irvine, California. so
Nice.
so when I read that about you, I was like, how is it possible that I come here from that part of the country and she
Yep.
moves there? So, as I mentioned, we're going to talk about how autoimmune diseases affect a lot of women. And as you are probably very aware, because you have many patients that will come around perimenopause or menopause time, they do have a lot of hormonal changes. What do you think about those changes, the hormonal changes? How will they affect the risk for females to develop autoimmune diseases?
Yeah. So menopause and perimenopause are definitely the time where we do see an uptick in things like rheumatoid arthritis and other autoimmune disease, Sjogren's, and things like that. There's a lot of hormonal changes that happen around this time. Typically in perimenopause, your typical cyclic changes in hormones go really haywire. So, whereas premenopausally, your estrogen goes up in the first part of the cycle, then it goes down, then you release an egg, then your progesterone goes up, then it goes down, then you have a period. In the perimenopausal time, your estrogen goes up and then it goes way up and then it bottoms out. And that's when women feel a lot of the classic symptoms of perimenopause, like hot flashes, night sweats, difficulty sleeping, joint aches are definitely something that we see around perimenopause and menopause. And sometimes it's difficult to figure out how much of that is hormonal, or do we need to go down the autoimmune route and have someone see a rheumatologist. But in that perimenopausal time, there are huge hormone swings that really affect how patients feel. And then once you go through menopause, your hormones are just low. They're not swinging all over the place, but they're low. And that can cause a lot of symptoms as well.
You know that there is a lot of discussion in the medical world about the role of estrogen. Is it protective? Is it not protective? Is it inflammatory, anti-inflammatory? We have this debate for many years. What do you think about estrogen? Is it really protective, or what do you think about estrogen through the life of a woman?
Yeah, so estrogen does a world of good, especially in that perimenopause and menopause time. So there's so many benefits to estrogen use. It helps keep your bones strong. So when women go through menopause and their estrogen is depleted, they're not making estrogen anymore. That's in those first couple years after menopause. That's when women rapidly lose bone, and ultimately it continues on. You can develop osteoporosis, which is thinning of the bones. Then you can break a hip and end up in the hospital. And so estrogen protects you from bone loss. If you don't have any underlying cardiovascular disease, estrogen lowers your cardiovascular risk, especially in women who start estrogen between the ages of 50 to 59 or within 10 years of their last menstrual period. That's the best time to start hormones. It can lower your risk of cardiovascular disease. Estrogen is good for your brain. It's not going to give you the memory you had when you were 20, but there are some cognitive benefits to using estrogen. And there's some very preliminary data, early data, where it might help lower the risk of Alzheimer's, but that's not set in stone. And we certainly don't use it to prevent Alzheimer's. And then estrogen is good for your hair, your skin, your nails, the vagina, the bladder. Typically, menopausal women get dryness, dry skin, dry
Mhm.
vagina, dry eyes, and estrogen can really help that. So there is a world of good, especially when started within 10 years of your last menstrual period.
Do you recommend creams versus patches, or this is based on your evaluation and the patient risks?
Yeah. So it depends on what you're treating. If you're treating systemic symptoms like hot flashes, night sweats, if you're going for bone protection or cardiovascular risk lowering, then you would choose a systemic formulation. And there are several formulations that you can choose from. There are patches that you wear on your skin. There is something called the Fem ring, which is a little flexible ring that goes in the vagina, and it provides a systemic level of estrogen. There's a gel called Divigel that you rub on your arm or your inner thigh. And there are pills as well. And then there are different types of estrogen. So there's estradiol, which is the bioidentical estrogen, which just means it's the same chemical structure as your own ovaries were making. And then there's also Premarin, which is conjugated equine estrogens. It's a combination of 11 different estrogens from horse urine. So there are a variety of different routes of administration. It's sometimes depending on the person. Oral estrogen has a increased risk for blood clot, although in the right person that's a small risk, whereas patches, and we also think rings, have a lower risk of blood clot or no risk depending on the study that you're looking at for patches. So when we discuss routes of administration, we take into consideration a lot of different things. If they're having vaginal dryness, maybe you're going to go the Femring route. The problem is insurance doesn't like to cover that one. So there are local vaginal estrogens that you can use in addition to a patch or a gel or a pill form of estrogen.
Because you mentioned the risk of blood clots. What is the risk of blood clots in general population and in people that are using estrogen creams or patches?
Yeah. So an estrogen cream, like there are estrogen creams for the vagina, those have zero increased risk for blood clot at all. It's really the systemic formulations. But if you look at it, high levels of estrogen increase your risk for blood clot. So actually, for a woman, postpartum is your highest risk for blood clot. Second to that is pregnancy. Pregnancy
Mhm.
puts you at a high risk for blood clots. Um, Birth control pills put you at a much higher risk for blood clot than hormone replacement therapy. So, hormone replacement therapy, it's actually really low. And it's really seen with the oral estrogen, and it's about 8 more cases per 10,000 women years when you use oral estrogen in a dose that's hormone therapy. So not a birth control pill, which is higher, not pregnancy or postpartum. But a patch, depending on the study that you look at, has a lower risk or no risk. So yeah, so I tend to use a lot of patches with my patients.
About 20 years ago, you remember that was a study that was warning us about the risk of using hormone replacement therapy, especially in women, because it will increase the cardiovascular risk. And I just heard you that actually that was not confirmed. Can you tell us a little bit about that?
Absolutely. So that was the Women's Health Initiative, and
Mhm.
that utilized a formulation called Prem Pro. And you, it was this huge study. There were women on Prem Pro, there were women on Premarin alone, which is just estrogen, and then there was a placebo group. And they stopped that study early because they found that women on Prem Pro had an increased risk for blood clot, heart attack, stroke, and breast cancer. And that got a lot of media attention, and women stopped their hormones and they were terrified. But what didn't get a lot of media attention is that when they broke down the data by age range, 50 to 59, 60 to 69, 70 to 79, women in the 50 to 59-year-old age range had a lower risk of cardiovascular disease, no increased risk for stroke, a decreased risk of dying from anything. But women in the 60 and above had an increased risk of heart attack and cardiovascular disease. And the reason that we think that that's the case is because estrogen, if you don't have atherosclerotic plaques in your blood vessels, estrogen will lower the risk that you'll form them. But if you already have an atherosclerotic plaque in a blood vessel, estrogen can disrupt it, and a little piece breaks off. And if it goes to a blood vessel in your heart, that's a heart attack. If it goes to your brain, that's a stroke. So there's this window of opportunity. The best time to start women on hormones is really in that 50 to 59-year-old age range or within 10 years of the last menstrual period. And if you're not sure, because women in their 50s can have atherosclerotic plaques. So sometimes if a woman has high cholesterol or strong family history of heart disease, I will order a coronary artery calcium scan to determine if I think there are plaques there that would be disrupted by estrogen. And if not, then I'm reassured by that fact. If they have a low score 0, then giving them estrogen can lower their risk of forming atherosclerotic plaques.
It seems like you do a very comprehensive approach, not just examining the breast and go to a badge, and I love that. You know that a lot of females with autoimmune diseases, they do have a lot of other symptoms like fatigue. They are in pain, they sleep very poorly, and that affects their life, but not only the work, not only the relationship with their kids, but also the relationship with their partners. And I'm sure that being a sexual counselor, you do have patients that will come to you and will share their challenges. What do they say? What do they share with you?
Yeah. So I would say the most common things I see are low libido and painful sex. Low libido is super common. And when you evaluate it, it's a pretty complex evaluation because there's so many things that play a role. So, with just some of the symptoms that you mentioned, pain and fatigue, forget about it. Sex is going to go to the very bottom of the list if you're in chronic pain or you're exhausted. But there's many things that can contribute to libido, from low testosterone levels to antidepressants that you're on to relationship problems to what your parents taught you about sex to pain with sex. It's a very complex discussion. And I find that it's when women come with low libido, it's usually not just one thing that's contributing, it's usually many. And the other thing to say about low libido is that I find that a lot of women are like, oh, it's me, I'm broken, I have low libido, I'm the problem. Not really. Why does the partner with low libido have to be the issue? Maybe high libido is the issue. And we know that in general, men have 10 times as much testosterone as women, although women do have testosterone. Typically, they'll have higher libido than women do. And so it's more of a desire discrepancy. And so I feel like it's important to not say you're the problem. You're not the problem. Your partner may be the problem. It's just that you're not on the same page about libido. But the goal really with, treatment or counseling is to find a solution that works for both partners.
I do appreciate that you say that, because a lot of my patients will come to me and will say, I am the problem. I
Yeah,
have the disease. The disease affects me. So I come in this relationship that is not, I'm not there. I'm not present in this relationship.
right, right.
Um, and it's always more complicated than that. Now, because you mentioned just one of the problems, we know that patients with Sjogren's disease, with rheumatoid arthritis, with lupus, with scleroderma, they do have a lot of other complaints. And you mentioned at some point vaginal dryness. What
Yes.
are some advices or treatments that you implement in your practice for your patients to address vaginal dryness?
So, the best way to improve vaginal dryness in perimenopausal and postmenopausal women is with vaginal estrogen. So, premenopausally, the vaginal tissue is thick, it's moist, it stretches, it has cells that make its own lubrication. And as women get into the perimenopausal years with lower estrogen levels, or the postmenopausal years with very low estrogen levels, the tissue gets thin and dry. It doesn't have as many cells that make moisture, and it doesn't stretch. It loses collagen and elastin. And then if you throw into that Sjogren's, or one of or scleroderma, it's like a
Yeah.
double whammy, right? Like they're going to be dry anyway, plus they have the lack of estrogen. So for those women who are lacking in estrogen, the best choice is estrogen for sure, a local vaginal estrogen. And local vaginal estrogen really has minimal risks. There's no increased risk for blood clot, heart attack, stroke, breast cancer, nothing. But I will say, if you prescribe a low dose vaginal estrogen, even though it doesn't have those risks, if you look at the package insert, it will scare you because it has a black box warning that says dementia, heart attack, stroke, breast cancer. But that's not true for vaginal estrogen, but the FDA mandates class labeling. And so that means that any product that has estrogen has to be labeled the same. So if you are worried about breast cancer or heart attack, or let's say you have breast cancer or something, and you look at that package insert, you might be like, whoa, what was my doctor thinking? But it's not true. And almost everybody can use a low dose vaginal estrogen. Now, there are other things you can do to moisturize and lubricate the vagina. Um, I'll typically recommend a lubricant for use at the time of sex, and then a moisturizer, which you can use whenever. So, when it comes to lubricants, there are a variety of different lubes. There's water based, there's silicone based, and then there are things like olive oil. And if you suffer from dryness, you want to avoid water based. So even though they sound natural, they sound better, they're actually drying. Just like if you soaked your body in a tub, when you got out of the water, your skin would be dry. So silicone based lubes, they're not absorbed into the bloodstream. They are much less drying. They're actually lubricating. They don't have to be reapplied as often, and they work very well. Or you can use the olive oil you have in your kitchen. That works too. You can also moisturize. So, just like if you washed your hands and then you got a pump of Vaseline intensive care, you can moisturize the vagina. And there are a variety of different moisturizers on the market. The one that I like the best is called Honor. But honestly, if you want, you could use coconut oil or Crisco. You don't have to buy one of the products. I just like it because it smells very good. It smells like roses, and you can use it for chapped lips. And it's just a good product overall. It's all natural. Um, and you can moisturize the vagina as much or as little as you want to. Some people will just take a little bit of coconut oil or the rosebud honor and put it on the outside in the morning at night. Other people will, every time they pee, they pat dry and then moisturize a little bit. You can get those moisturizers inside the vagina by freezing a little chunk of honor or coconut oil. You freeze a little chunk and then you can push it in the vagina. It melts at body temperature. So yeah, and that's not going to hurt anything. It's not going to increase your risk of infection, but it can really help because a lot of women with vaginal dryness, they're uncomfortable just walking or sitting or riding a bicycle, like a spin bike. They kind of feel that dryness, or even when they wipe. So the good news is there are plenty of safe and effective things that you can use for vaginal dryness.
Those are incredible tips. I did not know about them, and I'm so happy that you share them with the patients because they need to know about those things. And I don't think there is enough time in the regular traditional practice to address all these questions. And many patients will be very hesitant to open that box and
Yes.
to discuss those topics because they are very sensitive and very personal to them.
Yeah, and there are definitely practitioners who don't like talking about sex.
No,
So,
that's so.
there's already a it's already a difficult thing for patients to bring up, and then it might be difficult for a provider to respond. But, when you look at sex and its importance to our overall health, I mean, why are we still here? Food, shelter, and sex, right? So it's really, really important. And so, to your listeners, if you're having problems with sexuality, low libido, painful sex, arousal, orgasm, anything, you can find someone to help you. And actually, there's an organization called ISWISH, which is the International Society for the Study of Women's Sexual Health. So it's ISSWSH. And if you go to iswish.org, you can find a provider. So that
Mhm.
will alleviate some of that, oh my God, I'm going to ask a question and they're going to blow me off, or they're not going to know the answer, or it's so embarrassing. But it's so important. So iswish.org is a good place to find a sexual medicine practitioner.
Excellent information. And how about strategies that patients can use with their partners? They don't feel well. How will they be able, or how is best from your perspective, to communicate that and improve the sexual well being of the couple?
Yeah. So if you have underlying chronic pain or underlying fatigue, then you might want to maximize whatever treatment you're doing, figure out what is the time that you feel best and try to add intimacy or sex. It doesn't actually have to be penis and vagina sex, just intimacy of
Hmm.
some sort can be very fulfilling when you're feeling at your best. So that might mean scheduling sex, right? It might take away a little bit of the spontaneity because, 11 o'clock at night, you might feel not good. You might be in a lot of pain and be exhausted. So maybe you need to schedule sex on a Saturday morning or a Sunday afternoon or when you're feeling at your best. But there's no shame in scheduling sex. Like, I feel like some women are like, oh, but then it's not spontaneous. And my response to that is, was it ever really spontaneous? Because even when you were younger and you had a new boyfriend or girlfriend or new partner, you might have been going on a date and you picked your pretty underwear because just in case it might happen. So was it really completely spontaneous? Not really.
I love these advices. I think they're very powerful. Now, I hear some patients asking me, is using baking soda good to treat the vagina and treat the area if they have dryness? Is it really
Nope.
good? No.
Nope. Never heard that. So nope. Wouldn't do it.
Okay, good, good, good.
Yeah.
I would like you to tell us a little bit about your practice because your practice is unique, and I'm sure that there will be a lot of patients interested to hear how you practice and what you bring to the table for them.
Sure. So I'm a gynecologist by training, but I have three specialties: menopause, sexual health, and weight loss. I am at Evora Women's Health in St. Louis, and we are a unique practice. We're a concierge practice or a direct patient care practice, which means we don't accept insurance. But because of that, I can keep my practice small and I can spend a lot of time with my patients. So I came from a traditional system. I was an employed physician, and your boss said, you got to see 40 patients in a day. And I had 5 minutes with my patients. And as you can imagine, to discuss anything sexual, hormones, menopause, that is not a 5 minute visit. And I felt like my hands were tied and I couldn't provide the kind of quality care that I wanted to provide. So I left and started Evora, and my first visit typically lasts an hour. My follow ups are 30 minutes, more if you need more. My patients have my cell phone number. They can call me, they can text me, they can email me. I'm reachable. There's no firewall. They don't have to speak to a nurse and wait 3 days before someone calls them back. So there's really a lot of benefits for patients to this kind of medicine. And there's benefits to the physician too. I love being able to spend time with my patients. It was very frustrating to me that I couldn't provide the kind of care that I wanted to. So yeah, it's a unique way to practice medicine, but it's wonderful.
You also added in time more practitioners and you expanded the scope of your practice. Is that correct?
Yes. So what we found when I started Evora was me and my assistant. And we really found that there was so much more that women needed. And I founded Evora during the pandemic. So it was very hard to find practitioners. So we started adding them to our practice, which showed us the benefit of having so many different practitioners all focused on women's health in one location where we can talk to each other, which I love. So we have added an internal medicine doctor. We added a psychiatrist. And then we also have two dietitians. We have two personal trainers. We have marriage and family therapy. We have regular therapy. We have acupuncture. Love having that around. Chiropractic, massage, aesthetics. I know I'm missing somebody, but we really expanded so that way we have everything that a woman needs in one supportive space. And I love it because we all talk to each other. So we can really formulate a cohesive plan that so that we can give the best plan for a woman's health. So yeah.
And this is unique because you don't have to refer the patient to another practitioner that you don't know, you have no experience, you don't see how they are working. And
Right.
just the fact that you are together and you can customize the plan, this is
Mm.
really personalized care. It's
It
not
is.
like, it's not only said, it is crafted for the patient.
Yes. Yeah. It's not patchwork. It's not a little bit here, a little bit there, a little bit there. It's all together for one cohesive plan of treatment and plan of care.
And that's what I love what you're doing, and I praise your practice, and I many times I tell people about your practice because I believe it's truly unique and it brings everything that a woman needs and in the reality that they live.
Yeah, yeah, that's wonderful. Yeah, we're very excited, and actually, we're hoping to bring this to other states.
Mhm.
We're in Missouri, but we are looking to help other gynecologists and other women's health practitioners get started with a practice like ours.
Excellent. I'm gonna put in the bottom of this video, I'm gonna put the website where people can find you. And I hope they will find help by coming to your practice.
Thank you. Thank you so much.
And with that, I would like to thank you for giving us your knowledge. Your time is truly appreciated. And I hope to see you in many more episodes coming.
Oh, thank you.